Okay, so hello and welcome to another edition of the ERA Journal Club. I'll just briefly say that we are going to be receiving a talk, first of all, from Professor Foucher, and then we'll have a discussion session with our expert panellists, Professor Svensson and Professor Luuk Hilbrands. So I'll hand over to Professor Foucher now. Thank you.
So my name, as you say, is Yohann Foucher. I am a biostatistician and epidemiologist, and one of our last study was on the impact of the kidney transplantation in obese candidates. So we use an original methodology, I think, which is based on time-dependent propensity score. Probably you know what is a propensity score, but time-dependent propensity score is not so used. So I will explain the details of the method and why it is important to use it when we compare transplantation versus dialysis. Just few slides to introduce the issue. This data are in France. In France, we estimate that 23% of the dialysis patients had a BMI higher than 30, but this proportion decreased in the active list waiting for kidney transplantation. This proportion is only 20% in the list. And this proportion also decreases when we look at the prevalence of the obesity in kidney transplant recipients, because we estimate that it is 16%. So as you see, we can imagine that the obesity represents an obstacle to kidney transplantation. The question is why the obesity is an obstacle. So we have to look at the previous studies that compare the survival of kidney transplantation versus patients on waiting list in order to justify if we have to transplant or not this type of patient. So we identify two studies, but they had the same issue, methodological issue, that they do not consider the time-dependent confounder between the transplanted patient and the patient still on waiting list. That is the time-dependent confounder, that is the confounder that vary between the registration on the list and the kidney transplantation. So to answer this question, we have different possibilities, but one of the possibilities is to use time-dependent propensity score. We already use this type of methodology to compare transplantation versus waiting patient, kidney transplant recipient versus patient who wait on the list. And we apply this method here to evaluate the life expectancy between kidney transplant recipients obese at the transplantation versus similar patient on the waiting list at the same time post registration. So we use data from France. These data are the French Renal Epidemiologic and Information Network, the RAN registry. This registry includes all the patients with end-stage renal disease. And in our study, we only include the patient with the first disease between 2005 and 2018. We exclude patients with absolutely no information, that is to say, no follow-up in the registry, and we also exclude multiple organ transplantation. So just few slides to illustrate the idea of time-dependent propensity score. In this graph, we plot the transplantation likelihood, the probability of transplantation according to the post-registration time. And as you see in this graph, there is some patients that are transplanted at the end and some patients are not transplanted at the end. The transplantation is the point. So if you look at, for instance, the patient with the color orange here, this patient is transplanted at the end, and we match this patient with a patient with a similar probability of transplantation at the same time post-transplantation, but this patient was not transplanted at this time. So we make this pair, and then we repeat the method in order to perform the maximum of pair. So the next step in this graph is, for instance, to choose the blue patient. He is transplanted at this time, and we choose again a patient which is not transplanted, but he has the same probability of transplantation at this time. As you see here for this pair, the patient, the control patient which is not transplanted at this time is transplanted thereafter. So this is what we call, when we perform a randomized clinical trial, an intended to treat analysis. Even if the patient is transplanted here, or even if the patient transplanted return in dialysis, whatever, the patient stay in the same arm. We don't perform a per protocol analysis because, as you know, in randomized clinical trials, such a per protocol analysis can be associated with a large amount of bias. So at the end of this matching procedure, some patients will be not matching. And for instance, here, we cannot find a pair for the last transplanted patient because there is no patient at risk of transplantation at the same time. So in terms of modeling, we model the time-dependent propensity score, that is to say, this likelihood of transplantation according to a model that you know, because it is largely used in clinical research. It is a co-specific Cox model. And in this model, the outcome is the kidney transplantation. So we model according to this approach the probability of transplantation, and we include in this model some time varying covariates that, for instance, the BMIs that vary according to the time, also the comorbidities, the cardiovascular comorbidities, and so on. So we can consider the time-dependent confounders in this time-dependent propensity score. We choose to select 10 covariates in this time-dependent propensity score model, and we don't select covariate according to the data. We just ask the nephrologists, the experts. They perform a directed acyclic graph, that is to say, all the relationship between the covariate and the outcome, and we identify the confounder according to this expertise. Of course, and we will speak about it in the discussion, of course, we only consider the covariates we collect in this registry. So, of course, probably there is some missing covariate at the end. So just to be clear, for the matching procedure, we use a maximum caliper of 20%. That is to say, the tolerance of the distance between a case and a control. And we also perform an exact matching for the covariates that will be not balanced after the first matching procedure. So we repeat the matching procedure with some exact matching in order to ensure that all the possible confounders are balanced between the two groups, the groups which is transplanted and the groups not already transplanted at this time. Then, when we obtain this matching cohort, we use some usual statistical approach, that is to say, the Kaplan-Meier estimator in order to estimate the patient survival. We estimate the area under this survival curve in order to estimate the life expectancy. And in order to estimate the probability of transplantation in the control group, we use an approach that considers the competing risk between the death and the transplantation, which is the Allen-Johnson estimator. And we bootstrap all the procedures, that is to say, from the propensity score construction and outcome analysis. We bootstrap all the procedure in order to estimate the confidence interval of the results. So now I will speak about the results, which is important for you, I think, besides the methodology part of this talk. So what you have to retain is that we can obtain two matching cohorts. We construct two matching cohorts. The first matching cohort is a cohort of patients with a BMI higher than 30. And we obtain two balanced groups according to the characteristic of the patient at the time of the matching. So you see that the age at the time of the matching is quite balanced between the two groups. And this is the same for all the covariates and also the time-dependent covariates in between the registration time on the list and the transplantation of the patient in the transplanted group. So what we can say in statistics is we emulate a clinical trial. We don't perform a randomized clinical trial. We emulate a clinical trial. That is to say, we obtain two balanced groups, which are comparable in mean, as we have obtained if we randomize the transplantation at the time of the matching, that is to say, at the time of the transplantation of the case in between the two pairs. So as you see, the standardized difference in this subcohort are quite small. So this is one of the main assumptions to evaluate when we perform such analysis. So we perform this analysis for patients with BMI higher than 30, and we reperform this matching procedure to obtain a matching cohort of patients with a BMI higher than 35. In the French registry, we cannot use a higher threshold because in France, we don't have enough patients with a higher level of BMI. We will obtain too small matching cohorts because, as you see, we only obtain a cohort with 200 patients in each group. So, of course, if we aim to obtain this cohort for a BMI higher than 40, we will obtain just 20 or 30 patients in each group. Okay, so now, after this matching, we have to compare the survival of patients. So this is the survival of patients in the first cohort with a BMI higher than 30. And as you can see, the survival is quite comparable between the two groups. For instance, as I write in this slide, the survival at 10 years is 63% in the group, in the kidney transplantation group. And in the control group, that is to say the patient waiting for a transplantation, this value is 60%. So we have to say that, as I say before, that in the control group, that is to say the patient in the waiting group, they can be transplanted and they will be transplanted. That here you have the cumulative probability of transplantation in the control group. And as you see, that the large majority of patients will find a transplant. and they will find a transplant very soon because at, for example, 2 years, you have more than half of the patients transplanted in the control group. So we don't compare in this analysis, in this study, we don't compare transplantation versus dialysis. We compare transplantation versus a group not already transplanted, but they will probably transplanted soon. Okay, this is very important after to interpret the results. In the second cohort, we have two survival curves also, but we have less patients. So this is you see that the confidence intervals are very large, but we can see also that the two survival curves are very close, and the survival at 10 years is also very close. We have 57% of survival in the kidney transplantation group versus 59% in the waiting group. But as you probably know, because you are all nephrologists, the access to the transplantation is not so easy when you have a BMI higher than 35 compared to a BMI higher than 30. So as you see, the probability of transplantation is not so high in the control group, and this curve do not increase so quickly that in the previous group. So in the control group, the large majority will be transplanted, but the delay of the transplantation is higher than the matching cohort with a BMI higher than 30. So we will, of course, after this talk, discuss the result, but for us, the main result is that despite the fact that in the control group, there is a large majority of patients who will be transplanted. For instance, this is 80% for the patient with a BMI higher than 35. 80% of the patient will be transplanted. In the subgroup of the recipient in this for this patient who will be transplanted, the median time of transplantation is about 1 year. But despite the fact that the large majority will be transplanted and they will be transplanted quite soon, we obtain the same life expectancy between the two groups. That is to say that even if the patient stay in dialysis more longer in the control group, there is no impact on their life expectancy. So we can conclude that in the two cohorts, patients with an high-level BMI higher than 30 and especially higher than 35, they can probably have a waiting time on dialysis more longer than other subgroups of patients in the waiting list. And this delay of the possible transplantation can be used in order to try to lose weight of this patient. So this is a positive message. That is to say they can probably wait the transplantation. We don't say that we don't have to transplant this patient. They have to be transplanted. At least our study is not a study to say that they will we have to not transplant the obese patients. This is absolutely not the design of the study, but they can probably wait more than other subpopulation where we have a benefit on life expectancy when they are early transplanted. So today, because we have an organ shortage worldwide, the question is probably, do we need to perform such analysis in order to evaluate which patients have to be transplanted before the other one in order to improve the life expectancy of the overall population of patients on the waiting list? This is a question. Okay, so of course, our analysis, and I am statistician, so when we write the discussion of such a paper, I put a list of limitations, and the nephrologists say, okay, or no, this is a big list for the review. The journal will not accept our study. No, of course, we have a lot of limitation, and we have to know this limitation. I think the main one is that we don't analyze the quality of life of this patient, because we don't collect the quality of life in the RAN registry. But of course, our conclusions have to be tuned down, because if you spend the time on dialysis and your quality of life is not so good in this health state, probably our results will be very different if we don't center our analysis on the life expectancy, but for example, we can use the quality of adjusted life years in order to be more centered on the expectation of the patient. Also, but I think this is not a so important limitation as the first one, but also we probably, and I'm sure that we missed some confounders. For example, the social level of patients and so on. We don't have this type of information. So if we miss some confounder, we have remained biased, and some of the characteristics of the tool group are probably not balanced, and then we probably over or underestimate the difference of survival between the two curves. As I said also before, in France, the BMI is not so high than the other country. So I think that if, for example, in United States or in UK, where the obesity is more prevalent than in France, it will be very great if you reperform such an analysis in this country. First, to obtain a larger sample size in the matching cohort with a BMI higher than 35, but probably you can, I think in the US, they can perform analysis with a BMI higher than 40. In France, the National Health Agency said that the transplantation is contraindicated for patients with a BMI higher than 50. So we cannot go further in the analysis. And I just want to share with you the first limitation of the study. The only parameter which is collected in the RAN registry is the BMI in order to characterize the obesity. And as you know, the BMI is a limited indicators. And there is a number of discussions in the literature in kidney transplantation to use alternative indicators. And I think, again, it will be a great perspective to reperform this analysis in some cohort or registry where, for example, the waist circumference is collected in order to see if we can use another indicator for a better medical decision-making in kidney transplantation. So I finished my talk just to acknowledge the French National Biomedicine Agency, because we obtained a grant in 2019 in order to perform this analysis. So without this grant, we will not be able to perform this analysis, because this is a long time of data management and statistical analysis. And I will want to thank my two colleagues. We performed this analysis with three persons, me and Rémi Lenain. Dr. Rémi Lenain is a nephrologist and Today, I supervise his PhD thesis in epidemiology, and he is in Lille University Hospital. And my friend Christa Castelli, she is biostatistician in Montpellier University. So this is a talk that I present this talk, but behind this talk there's two friends. So thank you.
Thank you very much, Yohann, for that presentation. It's nice to have a bona fide statistician with us. I hope you're not intimidated by all the nephrologists. So can I just remind everybody that they can ask questions using the Q&A function, and we'll do our best to put them to the panel and to Yohann. So first of all, I'd just like to come to our two clinical nephrologists. So first of all, Prof. Hilbrands, I wonder if you maybe could tell us what you feel the strengths and limitations of this paper are.
Yeah, thank you very much, Kate, and Yohann, congratulations with this nice paper and a very interesting study. And personally, I think that it's very interesting to see that new techniques, new statistical techniques, this trial emulation can give us new answers to already long existing questions. Another strength of the study is, of course, that you had a very good data set that was very complete with all the major data that we needed for such a type of analysis. I also have some questions, and maybe you can address that questions now or later in the discussion. And I think when we look at this paper, we can have three types of questions. We can have a question about the methodology that was used. It's a new type of methodology, so not everyone is quite aware of all the pros and cons of the methodology, especially the choice for an intention to treat approach versus a per protocol approach. I think that deserves some discussion. The interpretation of the data can also evoke questions, and lastly, the consequences for daily practice. And if I translate this in a few more concrete questions, I would have, my main questions would be, can you comment again, because I think that's very important that everyone understands that well, that you choose an intention to treat protocol, and you already stressed it yourself. You did not compare transplantation with dialysis, but you compared transplantation with delayed transplantation. So was there also an opportunity in the study to do a per protocol analysis, and did the results really differ when you followed that approach? And I think one of the key points in the paper that presented in NDT was that was one of the key points on impact on practice of policy was that in obese patients there was a minimal impact of kidney transplantation on their life expectancy, and I think that is a conclusion that is more appropriate to draw when you did a per protocol analysis than an intention to treat analysis. Maybe you can comment on that. That's my first question. And the second question is...
I'll stop you there then just for 1 second, because that's a lot of questions. So will we deal with the first question and then come to the second question? Is that
okay?
Okay.
Yeah.
I think Johann's looking terrified.
Yeah. Thank you for your question, because we have this question systematically when we speak about when we speak with nephrologists, because we want to have this answer. What will be the result if we perform a per protocol analysis? That is to say, if we exclude from the analysis patients who will be transplanted after. And then if we perform this analysis, we will obtain two groups, one group with a kidney transplantation and one group with, at the same time, no kidney transplantation, and they will never receive a kidney. We try to perform this analysis before we perform, we write another paper before in another journal, which is Epidemiology. And this is very interesting to see the flow chart in this first paper, where we compare not only for obese the transplantation versus waiting, but for all the patients waiting on kidney on the list. And we see that when we perform the matching, we remove from the analysis all the patients who will never be transplanted. That is to say, there is a positivity relation. That is to say, people who will not receive any kidneys are not comparable compared to patients who have received kidney. There is too many confounders. And we cannot perform this per protocol analysis because there is not an overlap between the confounders. I don't know if you understand me, but you know, when we perform the matching, this is the machine performs the matching, but we see that all the excluded patients are the patients who will never find the kidney. So that is to say, there is no comparability between the groups. So 2 days, because the organization of the transplantation in France, we have too many confounders to perform this per protocol analysis. So we want to have this study. We want to compare this study because we will have a very important answer to the question, but we cannot. The data cannot answer this question.
To make it more clear, can you give some examples of confounders that were present in the patients that did never receive a transplantation, that stayed on dialysis, and the patients that underwent transplantation? Can you give some examples?
I don't have this example, sorry, but probably I can share. This is this paper in epidemiology, and here is the flow chart. So just 1 minute to remember. Look at when we match. So we work on the same history, but we don't select patients according to the BMI. We analyze all the patients in the registry to compare transplantation versus waiting. So we perform this time-dependent propensity score matching, and we don't match about 2,000 patients. And among these 2,000 patients, the large majority will never be transplanted. That is to say, we cannot find someone who has the same probability of transplantation in the control group, because probably these patients have a very low probability to find a kidney. So we don't find any control in any case for these controls. And this is probably a mix of several covariates, probably de novo cardiovascular disease, or cancer, or probably someone who have a very high level of immunity. Sorry, I'm not specialist of your domain, but I think this is a mix of all these variables, and so this patient have a very low probability to find a graft, but we aim to analyze this patient in order to perform this per protocol analysis. But there is too many confounders. So to answer the question, we have to randomize we have to make noise in the transplantation choice in order to have a mix of patients, and then but this is not possible with the data we have.
I think you are clear. You're saying that while all the patients are on the waiting list and you could assume that they are all more or less similar, it's not the case, and it's not a random selection of the patients that underwent the transplantation, but they have a different risk profile than the patients that did not underwent the transplantation. That's what you mean.
Yeah.
But how does this relate to your conclusion and the key learning points that kidney transplantation does have minimal impact on life expectancy in obese transplant patients. I think you cannot say that from the analysis that you did. You only showed that a delay in transplantation did not have a major impact, but here it is formulated that kidney transplantation has a minimal impact on life expectancy in obese patients. And I think maybe in hindsight, this is not quite the appropriate formulation. Do you agree?
Yeah. I think. Sorry for if I say something wrong, but my point is we can add a little quantity of dialysis in the control group. There is no impact on the life expectancy. So that is to say, we can delay for a few months, and some patients will not be transplanted in the control group, but there is no impact on the life expectancy. I did not mean that kidney transplantation have no impact on this obese patient, because if we say that, that is to say we don't have to transplant this patient. This is not the conclusion of this study.
Okay, thanks. Kate, maybe you are the chair, so
yes, I'm going to jump in if that's okay.
I have more questions, but maybe you would give someone else.
And we also have some questions actually about obesity and transplantation in general from a clinical perspective. So we should try and get to them as well. So from the audience, Louis Pedersen is asking, so Yohann, did you consider running the same propensity score-based matching approach among patients with a normal BMI with kidney transplantation compared to patients with a normal BMI on the waiting list? And if you did these patients have a longer life expectancy?
Okay, we don't perform this analysis. We don't have, probably we have to do, because it will be an additional results. But we perform the analysis. This analysis, as I said in this paper, you can take the reference if you want. This is a published paper in epidemiology, and so in this paper we perform the same analysis on the overall population of patients on the waiting list, regardless of the BMI. So probably we will have an answer to the question, and in this population, very shortly, you have here the life expectancy between the two groups, and you see that overall on the whole population, you have an impact of an early transplantation versus delaying transplantation. That is to say, we have to this patient, we have to have a short duration in dialysis in the overall population. So if I just want to deduce the results, if we have the same life expectancy for patients with a BMI higher than 30 or 35, and if in the overall population we have a better life expectancy for the transplanted group, that is to say that the life expectancy will be, if we perform the analysis, higher for transplanted patient versus not transplanted patient for a BMI lower than 30.
Okay, thank you. Mai, can I bring you in?
Yes.
Yeah, so
some of my questions have already been asked, actually, and of course I won't mention the same strengths with a large cohort and data again, but some of the limitations
I think my screen has frozen.
Patients that are obese to wait a little bit on the waiting list because they have the same life expectancy.
Sorry, Mike, can I stop you for a second? You froze during your question. Would you mind just asking it again? Sorry.
Oh, sorry. You said that you brought up a limitation that was quality of life. And I think that's important, because if you think of lifespan versus health span, you can say that the patients that are obese, they can wait a little bit longer. It doesn't matter. But that's kind of also an ethical question. How are you going to do that practical, and is that discrimination?
This is an ethical question about the, I don't know the term in English, probably this is in France is utilitarian, something like this in English. So, of course, if you say that someone will be prioritized to be transplanted versus someone who can wait, this is a sort of discrimination. This is if we do that, this is the price to pay in order to increase the life expectancy, the overall life expectancy of all the population. Because, to answer this question, I think we have to work on qualities, not on life expectancy. If we perform such a discrimination on life expectancy, I think it would be open to too much criticism. But if we perform such discrimination with qualities, I think it has to be discussed between patients, between nephrologists and epidemiologists and so on, ethical professionals also. But I think the question has to be have to be discussed because if we, in the other side, if you take some kidney wool because there is not too much kidney, and if you take the kidney to a patient that lost his life expectancy, so this is also an ethical aspect that you have to consider. I don't have the answer, you know. I'm not nephrologist, I'm not patient, and but I think the question can be discussed.
I also think that is. I agree with Luuk that you can't conclude what you concluded in the paper, and I think that is against everything we know, that it should be as good to wait on the transplant list than to be transplanted. This is comparable. It's against everything we know from before, so that's a bit difficult to accept as well. That it could be as good to wait than to be transplanted.
Yohann suggested that during the waiting time, the delay of transplantations, obese patients could have the opportunity to lose weight.
Yeah.
Do you have the actual data, Yohann, on this matter? Did you compare the BMI at inclusion versus the BMI at surgery?
No. I think this is only also a limitation of the study, and also it would be great to study the not only the loss in the BMI, but also the strategy you use to lose BMI. There is some question about the surgery. There is so this is questions that nephrologists discuss when we write the paper.
But Yohann, I just think as a clinician, it's really hard to get people to lose weight. And I think it's when they're already on the transplant list, I don't think that's realistic. But I have a sort of a practical question about the statistics because I don't understand it. I tried to read it many times. So what really happened with the patients that were that got transplanted? There was 60% of the patients that were on the waiting list. And you said you have an intention to treat. Did you censor these patients so they went out of the analysis, or I didn't understand that?
So no, we don't censor the patient transplanted in the control group because it will be a sort of per protocol analysis.
Yes.
So we don't perform it because it will be associated with some bias because we say you condition on the future. That is to say, your baseline is at the time of the matching, and then you select some patient on some trajectory on the future. So you don't know the future when you pseudo-randomize the patient. You don't randomize, you pseudo-randomize the patient. So we don't perform such analysis by removing the patient transplanted in the control group or censoring the patient in the control group, because it will be associated with a large bias in our analysis.
Okay, thank you.
So can I come to some more clinical aspects of obesity and BMI and transplant? So in the UK, in our centre, so in Glasgow, you wouldn't get on the transplant list if the surgeons didn't feel that you were transplantable. So they might have somebody who came to the clinic who had, you know, a BMI, let's say, of 40, and they decide that they have to lose 10 kilograms, and then they feel that they're transplantable. Now that varies throughout in different centres. So some centres will give a BMI cutoff, and they'll say, if your BMI is above 30, we won't transplant you, for example. But other places will look at the distribution of adipose tissue. So for example, somebody who carries a lot of weight on their hips, it might be easier to transplant them than somebody who's of the same BMI but carries a lot of, sorry about my dog, a lot of weight around their middle. So I guess the question to Luuk and Mai is really, what do you think in terms of using BMI as a cutoff? And what do you think about using other measures as a cutoff? And then finally, how realistic do you think it is to ask people to lose weight to transplant them? And do you think that is better than not transplanting them at all, given the benefits that we know from transplantation? So Luuk, I'm going to put those questions to you first of all.
Shall I start with one of these questions?
Sorry?
Go for it.
Well, I think maybe it's interesting also for the attendees to read the guideline that was written by the ERBP together with board members of the Descartes working group, and was published in NDT last year on obesity in kidney transplantation. And one of the messages of this guideline is that we should not stay on a strict level of BMI for acceptance for transplantation or not. Although most people agree that a BMI above 40 is a contraindication for transplantation. And below 35, it's usually not a contraindication. And in between, it very much depends also on other risk factors that are present in the patient, and indeed on the distribution of the body fat. And actually, it's very important to, I think, to use other measures for future analysis, like the waist circumference or waist hip ratio. But currently, the data on these parameters are not so complete in many centers that it precludes to have very reliable analysis on the predictive value of these parameters. So that are at least two answers, I think, to the questions that you had.
Yeah, absolutely. And so Mai, I guess, do you think that people who are borderline, so let's say somebody who's got a BMI of 35 to 40, do you think it's realistic to ask them to lose weight? And do you think that we do them a disservice by not transplanting them? Or do you think it's...
Yes, oh, sorry, I think we are very restrictive in Denmark, actually, with BMI less than 30, or in special cases up to 32. But I think it doesn't make sense to ask the patient to lose 5 kilos just to get below the magical line, sort of. I don't see the point. So I think we're being way too restrictive, actually, when you see the data from the literature. So I think we should loosen up a bit.
I think one of the other difficulties is, and certainly in the UK, and this isn't a criticism, it's just an observation, it's quite difficult to monitor things once somebody gets on the list, because we know that people who carry excess weight, who diet, often some months down the line, they may have gained back the weight, and there's not always a mechanism really for checking if somebody has managed to maintain a BMI target. So I think you're right that I'm not sure how logical it is to ask someone to lose a few kilograms.
Mm-hmm.
So Luuk,
yeah, a more definite solution for losing weight would be bariatric surgery. And that's, if we say above a BMI of 40, kidney transplantation is usually not recommended. Then the next question is, can bariatric surgery in this patient be performed? And the same applies for maybe for patients with a lower body weight that have additional risk factors in which you could choose for surgery as an option to lose body weight.
I was going to chip in there and just ask about the availability of bariatric surgery for this kind of purpose in your own centres. I know that we struggle to get access to this kind of thing for our patients in Glasgow. So Mai first and then Luuk, can you get this for your patients if you need it?
Yes, yes, we can, but it's a lot of private hospitals that does it as well. But there's no consensus, I think, about if you should do it or not. That's the other thing. So no consensus.
Okay. And Luuk?
Yeah, in the Netherlands, I think we have access to bariatric surgery for patients with overweight and additional risk factors.
I mean, the other things, I mean, you're absolutely right about the bariatric surgery, and that's certainly been sort of more of a feature in Glasgow, because as Yohann pointed out, we tend to have a heavier population than some other places on the continent. But even just simple things like a basic sort of weight management service where people can go for lifestyle and diet advice. These things are not very well resourced in our country. I don't know how it is in the Netherlands and in Denmark, in Denmark, or indeed in Norway, Mai.
No, there's also lack of resources for like ordinary advice from a dietitian. We don't have that.
In the Netherlands, since a couple of years, we have an opportunity for a so-called combined lifestyle intervention. And people with a BMI above 25 and with additional risk factors can have access to that kind of programs, in which they programs are usually run by a dietitian and a physical therapist, or a combination of the two. So we have these programs, but sometimes they're a little bit difficult to find.
Yeah, you can't help but feel that for a lot of aspects of medicine, if we sort of put a bit of resource, a bit of focus into these types of lifestyle things, we might see some results. So look, we're almost at the end, actually. You said you had some other questions. Is there anything that you have that you a burning desire to put to Yohann before we finish up? Yeah, on you go, Luuk.
Go for it.
Yeah, maybe I have a question to Yohann still about the paper. I was wondering whether he had the opportunity to perform a subgroup analysis to see whether the conclusions hold for all subgroups, for example, younger and older patients, living donors, deceased donors. Does it makes a difference?
Yeah, the main issue is we decrease the sample size of the matching cohort when we perform such subgroup analysis, and also this is statistically difficult because we have this subgroup analysis. This is not only I take the matching cohort and I perform some subgroup. We have to reperform all the propensity score. So it would be great to study several, not only the BMI as you say before. You study the BMI, you study the comorbidity, cardiovascular disease, hypertension, and so on, and then you will obtain a scoring system of the difference of life expectancy between transplantation versus waiting or delaying transplantation. But the question is the sample size, because if you perform such a subgroup analysis, as you see, we only have 200 patients per group without any subgroup analysis. So if we go further, we will have too small sample size. So I think this idea is good, but we need to have several registry together, or big registry. So this is probably an European project in order to perform such a precise analysis.
was just going to say, it sounds like an opportunity for worldwide collaboration and domination. So I'm aware that we are coming up to...
statistician.
Yes, absolutely.
I will be the statistician.
Absolutely. Something we're short of in Glasgow again. So I would just like to thank again Professor Foucher, Professor Svensson and Professor Hilbrands and the ERA for organising this session. I think that was a really interesting discussion. It certainly got my brain going, had to work quite hard to keep up with a lot of the conversation. So thanks very much, really enjoyed that.